Okay, so this is a paper which is based on research that was conducted over the last couple of years, and it was developed and researched with a colleague of mine, Pablo Lucas. At the time, Pablo was working here as a postdoctoral fellow. He's now based in Essex, University of Essex. So this is a paper that we are actually pretty much ready now finally to submit, and we're doing some further work. The presentation today, I suppose, is a little bit behind the curve in terms of the work we're just trying to map out for the final sort of stage of this paper before we submit it, but it gives you a very good indication of the material and where it has come to. Okay, so what we're looking at in the research is effectively a kind of health innovation policy in the health space in Ireland, and it's innovation within the public sector. And it's particularly looking at the establishment of primary care teams in Ireland. Now, the primary care team model is a model that's quite well known in certain other countries, particularly Canada and New Zealand. Less well known in many European countries. And in that context, Ireland, in terms of its introduction of the primary care team model, is quite ahead of the curve in many respects. The primary care team model is a model of care which brings together a range of different health professionals, including the local general practitioner, the local doctor or doctor groups, and allied health professionals. And the idea is that when the patient is attending their local doctor, that they attend that practice in the context of a primary care team structure, so that although they may approach their doctor in the first instance, if they need some kind of health intervention, that can be provided at the local level through the primary care team structure. And the main objective of this is to improve the health outcomes of the patient, but also to encourage a much more efficient use of resources. That's primarily the objective, of course, from the Department of Health, is to create a health system which allows many of the services that have been accessed either in a sort of silo form, so a patient goes to a GP, then is sent to a physiotherapist, and then maybe sent to a speech and language or whatever, that they are quite, traditionally quite siloed provisions, that they are now brought together in a team structure. So it's a much more efficient and hopefully effective structure. But that secondly, it also moves these services into the community, because in many instances you may go to your local doctor, but you will be sent to the physiotherapist who is based in the hospital. And so, of course, the hospital, which is really a centre of health intervention, which for acute cases and emergency case treatment, is trying to manage patients who really don't need that kind of health intervention, health support. They can be managed and treated within the community. So they were the two sort of driving forces behind the primary care team model in Ireland. We're using a case study approach, and we're really, as I said, trying to explore these innovative practices within primary care teams, and we're trying to understand really what happened as a result of the introduction of primary care teams in Ireland. What was the impact on the structure of network communication across different health professionals. So we look at where we are with our research so far. We're pretty close in terms of the final paper for this, and we'll also look at the results that have come from our ergo modelling approach on this network data. Okay, so then just to reiterate, the primary care teams were established in Ireland, and they're still, this innovation is not, universal across Ireland. It's still being rolled out, although it's, as a policy intervention, it's been in existence actually for about 10 years. But it is contested in different parts of the country. Different areas of the country, there's resistance from general practitioners, there's resistance from some of the health professional providers, the allied health professional providers, to move towards a team-based approach to intervention. Sometimes that reflects the costs involved, sometimes it reflects a perceived lack of structure to the way in which the team will be organised, or indeed a lack of understanding about how they will be positioned within the team. So these are some of the sorts of criticisms amongst several different criticisms of this intervention that are delaying the rollout of this primary care team model. But as I said, it's intended to try to, the model itself, the innovation is intended to try to mitigate some of the issues around access to public health care, and in the evaluation of the situation facing both patients, it's estimated, that who are currently only able to access services through their local hospital, for example, that most of the services that they are accessing through their local hospital, in fact, could be quite well delivered at the primary care level in the community. Okay, so as I said, while we have had primary care team policy rollout over a number of years now in Ireland, there are still many services that are geographically fragmented, and this particularly is the case in the west of the country, and they're not integrated into any kind of team-based approach. So the idea then is, of course, to introduce through primary care teams a much more integrated, multidisciplinary team, which should be focused on the patient, and so the patient becomes the centre of the communication and planning across these different health professionals. At the moment, the estimation is that there would be about 500 primary care teams needed to adequately service the country's population. Okay, so then the primary care team model is, in the literature, there's a lot of support for the theory, the idea that, we need to provide patient care in the community. It's the most supportive model for many of the conditions that patients need. It provides them an opportunity to access health intervention while remaining within their own homes, remaining within their own communities, being supported by their family and friends, rather than being discommoded and moved into a hospital setting, and all that goes with that change. So a push then to bring together teams, the Department of Health. This is an ongoing discussion between Department of Health, Health Service Executive, and the different interests involved in how to build out this model of primary care in the communities. But the placing of professionals in teams already in primary care teams, where primary care teams do exist and professionals have come together, even where that has been achieved, it has very mixed results, it seems, so far. Not just in terms of being able to map the delivery of healthcare in terms of the impact on patients and the outcomes on patients. So there's quite a lot of debate about how we actually validate the improved health outcomes of patients on the ground, for example. That's not well mapped in terms of a series of paths of care for patients. So we have, of course, in a hospital setting, paths of healthcare intervention reasonably well mapped out for many different conditions, but transferring that into a community setting and creating these paths of care in a community setting where you're looking at interdisciplinary intervention within the community. In fact, while it's well understood, it's not particularly well mapped out for primary care teams at that level. So there's a lot of discussion and debate about, well, how do we measure health outcomes at that level? But alongside that, and we aren't in this research, we haven't gone down that road. We haven't tried to evaluate primary care teams. That we are looking at in terms of, you know, pre-primary care team and post-health outcome outcomes, and try to assess the differences across these two points in time. What we are focusing on is the second aspect, which is highly contentious, is that when you have these teams in place, are these teams cooperating? Are they collaborating in the way which was envisaged? Are they sharing information? Are they looking for advice in the way you would expect a team to work together? Do you see an increased sharing of information across the team members? Do you see an increased seeking of advice from colleagues from different disciplines? Is there any evidence that we see a network structure that's becoming more dense, that's becoming less centralized, for example? Is there any suggestion that these teams are becoming collaborative teams in the sense that was envisaged in the primary care team model as set out in the original policy documents? Okay, so just to give you a kind of flavour of what these primary care teams, you know, what do they look like physically? Initially, when the policy was rolled out, it was envisaged that primary care teams would have a physical location, that there would be a building which would bring together the health professionals of the different disciplines, and that they would work together in a specific purpose-built location. And these are some of these examples of these primary care teams. Some have been purpose-built, others have been adapted. I've been to several of these primary care team locations, and they vary quite a bit. And there are, of course, you know, some very, very impressive purpose-built buildings, and others which, you know, are really adaptations of existing buildings, which are less, you know, amenable to group meetings and so forth. And so initially, when you visit, you think, well, you know, that's a good ambition to have a purpose-built building. But the reality, like I suppose many things maybe in Ireland in the last few years, is that the cost associated with building purpose-built primary care buildings has delayed that particular rollout of that part of the policy. So in fact, the Department of Health and HSE have rolled back from that initiative and said, look, we're going to push ahead with primary care team models, but we don't have the funding to support either in partnership or by direct funding the building of purpose-built primary care team settings anything of the same extent that we initially envisaged for this policy. And so in that sense, the policy ambitions have shifted a little bit. And so that, for our purposes, for the research, of course, muddies the waters a little bit in that sense. But even still, even in this example here, where you have a building that's being adapted to the ambitions around a primary care team model, it has, you know, it has a lot of advantages, even in that seeking to bring together professionals under the one roof, as was originally envisaged. But as we have looked at it in our research, we've decided to look at, because when we started this work, already that policy decision about pulling back from funding purpose-built buildings had been made and announced. We selected cases, some of which are situated in purpose-built buildings, and some of which are in much more disaggregated structures, where you have different parts of the team located in different buildings in the town, and where they come together regularly to meet, but they're not co-located in the one building. So we're trying to understand whether that has an impact on the potential for collaboration. Okay, so the objective then of the research is to what extent is there evidence to support the emergence of collaborative multidisciplinary teams? What extent is there learning across roles, across health conditions? We observe some of these effects by looking at the contact ties between network teams and the advice ties between the primary care teams. And then the second part of our research objective is to look at the key factors which drive the structure of communication in the primary care team network. So the overall focus then is to understand, are these teams operating as collaborative entities, and if they are acting as collaborative entities, we expect to find certain structures in the contact tie networks and in the advice tie networks, which would give evidence to that. And if we don't find those structures, then we argue that the teams, at least in terms of the case studies we've looked at in depth in our work, would suggest that there are real issues around how we build collaboration in the primary care team model, even where these teams may be co-located. So we're looking at our research then looks at to analyse the network structures that may support or inhibit collaboration and reinterpret mechanisms of communication versus where the formal structure may show a team structure, but the network communication as observed through contact and advice ties may demonstrate some other actual structure of collaboration in the team. We seek to try to look at short and long-term cooperative behaviour and to understand how individual behaviour and social structure may change over time. And in that way then we try to understand, I suppose, come back to the basic ambition of the project, which is to try to understand the nature of this innovation in the healthcare area in Ireland. How innovative. If innovation is about creating a new way of communicating through a structured team, an imposed team structure on a pre-existing fragmented health system at a local level, has that been achieved, and has the innovation been successful in that sense? So what do primary care teams look like? So the case study that we will focus on in this presentation at this point will be a case study of the primary care team structure in the southeast. We can observe in this example that there are 3 different primary care teams that we look at. So the first of these teams has the smallest of the population catchment area that it's seeking to manage, and then the largest has a population of about 7,000. These would be quite representative catchment areas for primary care teams in Ireland. In the structure of the primary care team, these would be the disciplines, the health disciplines that you would find in most primary care teams. So you can see that you have, of course, your local doctor, or often a number of doctors in the primary care team, and then a range of different allied health professionals and administrators. And outside of that team is a wider, so in the literature, the primary care team literature, they call it a network. So it's, in that sense, these are relationships that are less frequent with the primary care team proper, and involve a range of, I suppose, they're not really allied health professionals in the same way that you would call a physio or an occupational therapist, but they are professionals working in the health area, which may be drawn on in terms of the care of the patient. But these professionals do not or are not required to be part of the primary care team, and that means that they don't. They aren't expected, in the way in which these teams are structured, to meet formally with other members of the team on a regular basis. Whereas underpinning the primary care team policy, as it were, is the expectation that this team will meet regularly. Now, one of the difficulties with the policy is that it's a bit, on the one hand, it's highly prescriptive, and it's almost doesn't take any real account of whether, for example, the teams are co-located, whether they have pre-existing structures of collaboration and coordination. And so in effect, when you travel across the country and look at these different primary care teams, the actual implementation of that sort of norm that you would meet regularly is implemented in different ways. But probably it's fair to say on average, primary care teams would meet at least every 2 weeks to discuss patient cases. These professionals then are brought in, as I said, almost on a kind of case-by-case basis in terms of when they're needed for particular patient care. So in our case study that I'm going to talk about today, we're looking at teams, as I said, based in the southeast. It's quite representative of a large provincial setting, so it's a nice case study from that perspective. It's a large market town with significant rural and urban populations. And it's interesting also because of the structure of the primary care teams, because it's quite typical of what will emerge and is emerging in many rural, and by that I mean outside of large urban centres such as Dublin, what will and is emerging in terms of the way in which the allied health professionals are mapping onto different primary care teams. So in this instance, what you have is you have a group of allied health professionals, these are the physios, the OTs and so forth, who are actually servicing 3 different primary care teams, the same group. And one of these primary care teams, in South East 2, the allied health professionals are co-located in the same building as the GP and the public health nurse. The same group of allied health professionals travel to South East 1 and travel to South East 2. They're not located in the same physical space as is the case for South East 2 primary care team. And so that became something that we were very interested in, whether the structure of communication and advice giving might reflect this distinction in terms of their co-location of these different professionals. My apologies. It's South East 1 which is co-located. We need to rename these maybe, but my apologies, so I'm confused there. In this grouping here, health professionals are located in the same building as South East 1, whereas they travel to South East 2 and South East 3. Okay. All right, so just a little bit about our data collection. We created a network survey for mapping access in terms of regular communication, advice giving, and we looked at a number of different kinds of network ties, but I'm just going to discuss those kinds of ties today. And we collected the data via online survey. So each of the individuals within the primary care team was invited. Well, we did quite a bit of preliminary work where we contacted the managers of the primary care teams and sought access to the primary care teams, and then once having been given access, we were then allowed to survey each of the members of the primary care teams in terms of a social network survey, which asked a whole range of different kinds of questions, both in terms of individual attributes and characteristics as well as their network communication. And we did this all online, or at least we attempted to do it all online, initially at least. Interestingly, we found that some professionals were very happy to participate online, were very trusting of the survey that we had set up. We felt that we were dealing with very busy professionals. Certainly when we did a lot of our qualitative work and you know, semi-structured interviewing, we were forever hearing, you know, I'm so busy, and so we really didn't want to impose on these professionals, and we thought, well, let's send them a survey link and they can fill it in at 10 o'clock at night with a cup of coffee if need be, rather than take up time from their busy schedule. But in fact, that did work for half of the professionals, but many of those, and it was interesting, the public health nursing professional group were those least likely to complete the online survey. Whether that's because of the technology they generally work with, whether they don't generally work with on, you know, a computer or laptop, they're often in the field working with patients on a face-to-face basis. Maybe they're just not working with IT technology as much as other professionals, perhaps, in their day-to-day work. But they really resisted being involved in the collection of data online. So in those instances, we had to decamp down to the southeast and meet with the nurses and others who hadn't completed the online survey and complete a traditional face-to-face paper and pen survey, network survey. But we managed to get a reasonably good response rate, given that it was a network survey. In the end of the day, after some you know, decisions that had to be re-looked at and reworking of our research design, our initial research design. Okay, so what are the kinds of questions then that we were interested in asking our primary care team members? We wanted to look at, you know, primary care teams are, by their very nature, dealing with, you know, it's general practice. So it's a whole range of different conditions that they may be dealing with at any one time. And we found out quite quickly in the interview work we did before we ran the survey that, of course, as you would expect, some conditions would naturally look for the involvement of particular kinds of professionals more so than others. And some health professionals might be involved anyway in a range of different health conditions, whereas other professionals would not. So, for example, you might expect a physiotherapist to be involved in the care of a patient, perhaps in terms of mobility issues, in terms of managing depression perhaps, or diabetes or stroke, but a speech and language therapist might only be involved in maybe managing patients with stroke conditions, for example. So professionals, by you know, the nature of their training, would be involved to more or less an extent on different patient care interventions, and that was important to know, because of course that would mean that their advice networks might be different, because then of course you would more likely go to your physiotherapist on a range of different conditions and patients than you might go to your speech and language therapist. So you needed to be aware of that. So, okay, so we were interested also, so apart from being aware of that distinction, we also sought to then try to identify a range of representative conditions that the team would often deal with. And so we with various interviews identified a list. So we interviewed, you know, all of the different kinds of health type, at least one of the health professional types from the teams in the initial semi-structured interviews, and collated a group of conditions which our expert interviews agreed were probably the most representative of the kinds of things that they were managing within the primary care team, and they're listed here. And then the second part of that process was also to identify whether we could distinguish particular types of patients that would be, I suppose, you know, if we selected a type of patient, would that be representative of a large amount of the work that primary care teams were engaging in? And for that reason, we decided to look at the health conditions, these health conditions in relation to elderly patients. And also the fact that, of course, because demographically we're, like many European countries, moving slowly, much less rapidly than some of our neighbours, but we are moving towards an ageing population to some extent. This was likely to become more and more of a focus for primary care team intervention. So it seems sensible to take a look at these conditions in respect to elderly patients for primary care teams. And primary care teams deal with lots of different kinds of patients with lots of different kinds of conditions. So this is a selection that we have made in consultation with the experts that we interviewed early on. So we asked them, so having done that, we then wanted to understand whether primary care teams would look, if you were a member of a primary care team, you know, did you observe being part of a primary care team increased your capacity to manage the health conditions listed here for elderly patients? And similar kinds of questions were also asked of each of the members of the team. Has your primary care team improved capacity to respond to the following conditions, and has there been an increase in appropriate referrals to you since the primary care team? Now, these questions are actually mapping onto a similar survey that was conducted in Canada, where there is also a very strong primary care teams policy in place, and so we tried to really, I suppose, replicate some of the survey questions that were conducted in that study as a means of being able to try to see, really, I suppose, having a benchmark of the Canadian study to see where Ireland was in terms of its primary care teams and its impact on professionals and their learning. To what extent were they learning across roles within the primary care team and with respect to their own role? So the evidence of learning was quite mixed, I think, is probably the best way to put this. That you see that there are, we've identified a range of different survey questions. We said, you know, have your referrals improved or changed? Has your team capacity, you probably can't read that actually, did it? Has your team capacity improved, disimproved or changed? And has your own capacity disimproved, improved or has there been any change? What you see then across the different professionals, these are OT, public health nurse, physio, practice nurse and psychologist, you see that certainly in terms of appropriate referrals, that generally there hasn't been a major change in the referrals that they are receiving. Now the reason why that's important is that you would expect, as being part of a primary care team, that once you are more familiar with what your colleagues are, what their role is and what their work is, that they would be more able to accurately refer a patient on to the appropriate care and do that, and that would be an improving system as opposed to a static or disimproving system. Because in the training of healthcare professionals in Ireland, and this is the case internationally, it's often the case that health professionals are trained separately, one from the other. So medics are not generally trained with speech and language therapists. There may be some overlapping modules, but there's not a great overlap in the kind of training that they receive. So in that case, then you find that, you know, you may have a general knowledge of what, you know, physio does or what an OT does and so forth, but you may not have really detailed case study knowledge. But the idea behind the primary care team model is that now you bring a team together, they discuss patient cases together, and they learn as a result of that discussion how best you might intervene in different conditions. So we would have expected that the referrals would be improving, or at least that there would be some pattern of change. Now, this is a static snapshot of these primary care teams. but certainly on the appropriate referrals map marker, there is very little evidence of improvement, and for most it's no change, which is our first finding, I think. We have also then a set of statistics, descriptive statistics presented here visually, which are really indicating whether the team capacity has improved from the perspective of individuals completing the survey. And again, the results are, I suppose, disappointing in the sense that you find quite a lot of response which suggests that there is no real change. It's more optimistic maybe than our referral data, in that there is some of the professionals, in particular the physiotherapist and the psychologist, who are indicating that there is some improvement in the team capacity. And again, when we look at own capacity, again the pattern is quite similar. There is some evidence of improved own capacity, again the physiotherapist and the psychologist, but many of the professionals have indicated that there's no change, there's no real learning evolving from the primary care team membership. We have a similar set of results when we look at looking by role. So in this instance, we look at the again referrals and capacity, and here you are looking at in this instance we've simply just clustered together a range of roles, and the results are quite similar. Again, there's either no change whatsoever, or very little improvement over time. So I'll leave that slide is a little bit confusing. I'm going to move on and come back to that in a minute. So this then is our first set of network results, which indicate the level of contact that exists in the Southeast primary care team. So what we're presenting here is initially the results where we combined the 3 primary care teams together. So you are seeing the results for contact. This is where all the team members of the 3 teams are put together, what level of contact exists across these 3 primary care teams. And we have disaggregated, we've done the same work here, but looked at where we've put together all physiotherapists. We've grouped them into one group, into one actor, and so on. We've put together actors in terms of their professional training. So in what sense is there contact between physiotherapists and occupational therapists, physiotherapists and public health nurses, and so forth? Yes.
Can you tell us what a contact looks like and how you measure it?
The contact was asked in 3 different ways. So we asked the respondent to indicate, had you any contact with this professional, and we listed all of the professionals in the primary care team. So had you any contact with this individual in the last 2 months, in the last month, on a weekly basis? So we were trying to get a measure of how frequent the contact was between.
From a telephone call to a case contact.
Yeah, so that's just a sort of almost like a benchmark. And in our reworking of this material, probably we're going to take out that data. We're still sort of looking at it a little bit, because it's somewhat confusing in one sense, because of course contact is a very open kind of idea. It can mean anything, and it's not as informative as something like advice giving, which we have phrased in the survey so that we're really looking at medical advice, the sharing of medical advice. But nevertheless, it's still quite interesting to look at it as a starting point in terms of what level of communication exists across the primary care teams in the Southeast. And what you see then is, I suppose, when you look at a course over a period of 2 months, then it's quite a dense network. But when you look at the weekly communication network, it becomes less dense in its structure, perhaps. It's less. There are certainly communication ties, but they're between particular types of health professionals as opposed between all the health professionals, which is what you would have expected if the primary care team was working as set out in the policy.
So are these two networks include different types of actors? So for the first one, is it individuals or roles?
These
so
are
roles.
These are roles. These are this is the physiotherapists and so forth. These are individuals. Yeah. So so we can take a look at actually the network survey questionnaire in terms of how we asked that question. So it was simply, and this is the advice question. So the professional was asked, if you're dealing with an elderly patient who has a mobility issue, who would you go to for advice? And the same question was asked for all of the different conditions that we were focusing on. And this is a very standard survey, network survey question. The individual was then asked to tick which of the members of the team they would go to for advice in their team, basically. So they had the option of choosing multiple others in their team that they went to for advice. So that's the sort of survey question structure that was used for the work. Okay, so if you look then at the structure across all of these different conditions, you see that this is over 2 months. You see that there's apparently quite a dense network. Some professionals are certainly much more centralised with respect to all of these different conditions than others. That's for sure. There are some of these professionals in the primary care team structure that are much more connected to many others, and others are much more remote in the network. But overall, it seems at the 2-month level quite a highly structured, highly connected network.
So we include both the primary care teams and the
allied health professionals.
Yeah.
Yeah, we combined the 3 network team data sets for this research. Then if you start to look at it now in terms of roles, what you're observing now is, and that's a little bit unclear, so what you're observing now is I suppose again across these different conditions, and you can read across stroke, depression, diabetes and so forth, you see some pattern, some variation in terms of the level of connectedness across the different health professional roles, but it's not highly connected network, and in some instances the network, the actors involved were very, there were much less actors involved in that treatment intervention than we would have expected. So that was also a surprising result for our work. Okay, so what then did we do next? How do we look at this data in a more, I suppose, statistical perspective? We decided to look at the networks from the perspective of degree and centrality, and look at them in a range of different measures. You're all familiar with those, I'm sure. And the results then for our primary care team study, well, I'm going to go through them now. We've already taken a little look at some of the descriptive data results, but I'm going to look at it now from the point of view of an exponential random graph modelling approach. And in this model, we're aiming to try to test some assumptions about the network structure of advice giving in the team. And we are working with an exponential random graph because a modelling approach, because it allows us to test some of the structural hypotheses that we would like to see whether they are characterizing our network structures better than others. So we if we assume that there will be a decentralized, densely connected network, then we can test that with our ERGM model, looking for those kinds of structures in our network ties. However, if we are also interested to look for the opposing hypothesis, which is that the structure of the network team, the primary care team, in terms of its advice-giving network, has not resulted in a decentralized approach. In fact, much of what we're observing in the team is reflecting a fragmented collaboration. So you don't find that there are, you're as likely to be asked for advice as a physiotherapist as other health professionals in your team. Rather that you find there are individuals in the team who are very central to the overall team, then you could, we argue, you could suggest, this suggests that the team is not really collaborating, that in fact what's happening in the team is that you have a very centralized structure with maybe just a small number of health professionals who are really involved in all of the key decisions around patient care, taking account of the fact that for some conditions that may be the case, that you would expect some professionals to be more involved in that condition than others. But taking that into account, if the primary care team model is innovative, is working, you would expect to find a decentralized structure in the collaboration advice network ties. If that doesn't exist, we suggest that the team is not working as a collaborative entity, and that in fact it's really hasn't moved beyond what existed prior to the primary care team model being implemented. So in the ERGM model, we simulate the network structures that we're interested in looking and testing for, and we compare those with our actual cross-sectional data, and we look to see what are the statistically relevant network structures that actually exist in the network data that we have, and what does that tell us then about the collaboration. So this is a set of the results, set of the summary of the results that we found in our research so far. So in looking at, and I think the descriptive presentation maybe began to show some of those findings already. The multidisciplinary team structure is very hierarchical, despite taking account of health conditions where you would expect, for example, a physio, a GP, a public health nurse to be involved, and perhaps a psychologist to be involved in the care of the patient almost equally. So you would expect quite strong centralized positions for those different health professionals. What in fact we found was that the key professional groups that were most central across all these health conditions in the different primary care teams that we looked at were the GP and the nurse. And so what that means is that even bringing them together as teams to try to create strong team-based collaborative activity and advice giving isn't resulting in the desired effect. In fact, what it's actually doing for GPs in particular is it's funneling now even more work through the GP than might have had been the case before the primary care team was put in place. And this is one of the problems with the rollout, the further rollout of the primary care team model, because in Ireland the general practitioner effectively runs a business. It's a private business. They don't get funded by the state, whereas the allied health professionals, of course, do get funded by the state. They are publicly funded professionals. So there's a considerable resistance on the part of many general practitioners to engage in primary care teams because they see it at the moment as simply just creating more work for them as opposed to really creating a more rational approach to the management of healthcare. The bottleneck then has this, emergent bottleneck that you see, of course, then has all kinds of consequences for decision making and for the ambition behind the primary care teams, which was to create a cross-learning model and growth in the sort of recognition of what each professional could do in the case of complex healthcare intervention needs. So at the top of the network, particularly for our physiotherapists and psychologists, you see that they are quite enthusiastic about the model. Their learning has certainly increased, but the GPs, who are the ones who are mainly, and the public health nurses who are involved in nearly every kind of decision making around health intervention now in these primary care team settings, are reporting a much in terms of their non-engagement, particularly in the GP part of this model going forward, suggests that experience of being involved in the decision making is mixed, and GPs themselves, in terms of their national organisations and bodies, are resisting the rollout of primary care teams at this point because of the perceived additional burden that they feel they have to take on by being involved in primary care teams. In terms of our ergo modelling results, we identified this by looking at which of the network structures best matches the advice networks of our primary care teams, and discovered that the alternating K-star is the most statistically significant, which is effectively a very simple model of centralised network structure, and effectively suggests that we have in fact created a kind of gatekeeper model for primary care team intervention and collaboration, as opposed to a collaborative model of advice giving. I think I've probably reached my limit. I can go on a little bit more and talk a bit more about it, but I think I should probably stop because we have at least one other paper to be presented. I have a few more points to make, and maybe there's a couple of questions, and I can come to those then in the questions section.
I have a couple of questions. One is that, so that have you linked the network results with your outcomes, with improvements or not?
Mm-hmm.
And so that's the first question. The second part, I was trying to think of some of the possible recommendations as a result of your identification of the bottlenecks.
Yeah.
One is that, which is very naive because I'm in a system, the health system too, where they have teams of GPs. So rather than you seeing a single GP, they're either in rotation, depending on when I call them and so forth. So I get to see different GPs. Whether this would relieve the burdens, so that you identify the bottlenecks, and so the nurses, the second times doing the people, so you either increase the pool of such actors, or do something so that would that be a possible recommendation?
Yeah, I mean, I think in fact in the primary care teams themselves, when I mention GP, I usually am referring to such a team of GPs.
Oh, it's already.
Yeah. So, but traditionally you have a GP who is linked to a patient.
Right.
But within a GP practice, those patient cases can be shared across GPs. It's I suppose to some extent that would alleviate the pressure on an individual GP. But I think the problem more is that the GPs themselves feel that they are now, on top of meeting with their patients, they're now needing to meet in these primary care team structures. The system is working in such a way that they are now being involved in spending more time dealing with other health professionals' health decisions, rather than a patient comes into the primary care team, there's some sort of triage system and they don't need to go to the GP, but they go straight to the physio or the speech and language therapist, rather than coming to sit as a case at the desk. They meet as a team, and it's this, when you talk to the GPs, it's even just the weekly or fortnightly meeting of patient cases that they resist. They now feel they have to deal with these where they didn't have to deal with them before, and they have to spend time talking about problems that are outside of their scope, rather than actually finding that they're being alleviated by problems. So traditionally, somebody would come in and the GP would, you need to get some physio for that, so let me recommend you this person. The idea behind the primary care team model was that didn't even have to happen, that they would go straight to the physio in the primary care team. So maybe some kind of triage process is needed, similar to what happens in a hospital setting. But interestingly enough, on this paper, we have brought on board the famed Brendan Drum, who was the instigator. He was our CEO of the Health Service Executive. And Brendan has decided to work with us on this paper. Brendan, at the end of his career as CEO, he was CEO, I think, of HMS, that his title, Chief Executive Officer, or certainly the main man in charge of, and he's actually a professor of medicine here in UCD, but he moved into the public administration and really instigated this primary care team model in the HC. But by the end of his tenure, he was not a well-liked man because of all kinds of things, including the primary care team model. But he has decided to come on board on this paper, and he's offering us his advice in terms of the policy implications. And what he can see as one of the key problems of the primary care team model at the moment, the way it's rolling out, is that it's this path of care in the community that's unknown. So it's not that there's not a recognition of the need for a primary care team. It's not that all the health professionals don't want to work together as a primary care team. It's that they simply have not sat down and, as a medical community, mapped out, if somebody comes in with this condition, who goes, where do they go to? And it's because there's this lack of information that the natural tendency, in a sense, is to go to the general practitioner, who is still seen as the sort of over manager, as well, of all these health professionals. So that would be my answer to that. Yeah, Philip.
Yeah, really interesting stuff. I guess one of the things I'm particularly interested in is trying to identify the sort of key factors that give rise to greater or less centralization, hierarchies. And two comments in relation to that. One would be that my GP doesn't have a work email address. He works in a teaching practice associated with UCD, so he's not sort of a backwards kind of guy, he's towards the fore. And when we do scans and blood tests and so on, the stuff comes in by fax. Okay. So one of the crucial things here has to be the use of IT, and the extent to which people are communicating via the web and the internet rather than talking to each other, phoning each other, and sending each other faxes. So that's one observation. So if you can get some handle on that, it might help to explain whether there's variation in the extent of centralization, decentralization, communication, and so on. So that's number one. Second point is that you're describing a service organization and a workplace, and it seems to me that Weber has a lot to say about these kinds of things, particularly what he has to say about status and power and about bureaucracy. And it seems to me that it would be very, very interesting to look at who's occupying some of the key positions. So, for example, we would expect that some of the key positions would be occupied by GPs. So are they old white guys? Or are they younger females? When were they trained and how were they trained? And those kind of factors must have some impact on the way in which they communicate with other health professionals and the extent of centralization and decentralization. So I guess I'm suggesting that there are some really quite old sociological ideas that are rattling around that could help you to explain variation in kind of outcomes that you're interested in.
Yeah. And the good news is that we have some of that data collected. So in our survey, in our network survey, we collected the network data, and we also, as I said, mapped this Canadian data, which was really very useful in terms of attributes, including demographic data. I'm not sure we have data. Yeah, we did actually look also at data around when were they trained and so forth. So their length of service and when they initially started. So we could, you know, so some of these kinds of characteristics could be looked at in terms of the sort of Weberian view of themes. Yeah. Thank you, Travis.
Did you mention that the GPs? Did you mention that the GPs, they're the ones who are running the business?
Yeah.
So could their resistance to that new model where someone goes directly to the physio and not to them first, could the fact that they're running a business play a role there? Did you mention that?
Yeah, I mean, I think, you know, in many ways the primary care team should have been felt by the general practitioner, the doctor, as a sort of, you know, a gift, really. You know, now they were being given publicly funded allied health professionals to work in a team structure with them. So, you know, that access, that weekly or fortnightly access, should facilitate the opportunities for GPs to make use of those publicly funded, which are not on their payroll. So, you know, it should have speeded up that process. But I think first of all, because the GPs they feel that their workload has increased considerably. They still have, you know, they still have the same numbers of patients, but they now have to make a double set of or triple set of decisions around the care of those patients. It doesn't seem to be, you know, the patients are still coming to the GP. You know, often because of the way the structure of the team is set up and the way in which the patient observes the team, they still come into the primary care team and they say, oh, I need to go and see my doctor first, and then my doctor is going to refer me to wherever I need to go. Whereas when we go into a hospital, we go in and we at some point expect to see you know, a consultant or a house doctor or whatever. But often we will work very well with the triage nurse. I mean, we may even be referred to a physio or to some other lab for tests and so forth. Within a hospital setting, they have developed this multifunctional, this multidisciplinary approach to care, not to the same, you know, not so that the consultant or the doctor has disappeared out of the equation, far from it, but they are able to create pathways for the patient more than seems to be the case at the moment in terms of community care. So it's both pressure from the GP in terms of, I'm running a business and I now have to spend some of my time that I could have used to write up my patient records to sit at a primary care team meeting, which isn't actually bringing any more business into me as a business as such, because I still would see these patients anyway, really. And the patient themselves doesn't quite understand the process. They go in there and they expect to see their GP. They don't expect to be seen by maybe some intermediary group professional who would then direct them towards to the relevant professional care that they need. So there's a lot of work around that being done. And then I think that would then bolster the kind of things you were talking about, Philip, which is, well, I've always been involved. This is what I've always done. This is my status. This is my role. I'm not going to move yet because I don't see any benefit to me to do that. I don't see any rewards. One more. Well, I'm wondering, should we leave it later? Because I don't want to exhaust people.
Centralized, decentralized. I was like the distributed versus co-located work teams. But I think that question was kind of asked already.
Let me move off and give Naseem